Welcome to the HIGN seminar series. Today we'll be discussing family caregiving for people with dementia. The burden of caregiving in the United States is increasing. In 2015, there were an estimated 34.2 million unpaid family caregivers in the United States. And in just 5 years, that number has increased to 41.8 million. As our aging population increases with baby boomers and increased longevity, the need for caregiving will only increase. So we're delighted to have 3 experts with us today to share their insights from different perspectives. My name is Tara Cortes, and I'm the Executive Director of the Hartford Institute for Geriatric Nursing. This is the 3rd of our seminar series, and today our first speaker will be Dr. Kalisha Johnson. Dr. Johnson is a postdoctoral fellow and a T32 National Institute of Nursing Research postdoctoral fellow at Emory University, Neil Hodgson's Woodruff School of Nursing in Atlanta. Dr. Johnson graduated with a PhD from Oregon Health and Science University in 2019. In her postdoctoral fellowship, she's focusing on the decision-making processes regarding formal paid care in an institution for African-American persons living with dementia, and how these processes affect the quality of life of African-American persons living with dementia and their families. Our second speaker will be Dr. Brody. Dr. Brody is the Associate Director of the Hartford Institute for Geriatric Nursing and an Associate Professor at NYU Rory Meyers College of Nursing. He is the founder of Alleviato Health and the pilot core lead of the NIA Impact Collaboratory. His work focuses on the intersection of geriatrics, palliative care, quality, and equity. And our final speaker will be Dr. Tia Powell, who is a professor at Albert Einstein College of Medicine. Dr. Powell holds the Treckenberg Chair in Bioethics at Albert Einstein College of Medicine, where she is professor of epidemiology and psychiatry and directs the Montefiore Einstein Center for Bioethics. She is recognized for a scholarship related to the allocation of scarce resources in public health disasters, dementia, LGBT issues, and end-of-life care. She was a Next Avenue 2019 Influencer in Aging and was named as a Crain's 2019 Notable Women in Healthcare. Her book, Dementia Reimagined, Building a Life of Joy and Dignity from Beginning to End, was published by Penguin Random House in 2019. The 3 panelists will give us introductory remarks about their own work, and then we will have a conversation amongst them to address relevant issues. This will be followed by a 15-minute Q&A from the audience. Please put your questions in the Q&A box, and if you have comments, put those in the chat box. We will address as many of your questions as we can. Dr. Johnson, please begin.
Thank you so much. My apologies, it's taken me a little while to get it all set up, but hello everyone. My name is Dr. Kalisha Johnson, and my presentation is entitled Understanding Decision-Making in African-American Dementia Dyads. Dementia dyads, I will use this term throughout the presentation. Dementia dyads consist of 2 people, and here I'm referring to the person living with dementia and their care partner or caregiver. So while the exact number of persons living with Alzheimer's disease and related dementias is unknown, research suggests a little over 6 million people were diagnosed with Alzheimer's disease and other related dementias in the United States. And African Americans are estimated to be 2 times more likely to develop Alzheimer's disease and related dementias when compared to non-Hispanic white older adults. Since there is no cure for dementia, the gold standard, so to speak, is to treat with medication when the person has mild dementia symptoms to slow the progression of these symptoms. Yet, given how African Americans entered the United States and with the mistreatment that has occurred in both medicine and research, many African Americans are often hesitant to seek these services and are diagnosed later in the disease trajectory. In the recent Alzheimer's Association 2021 Facts and Figures, 50% of Black Americans reported discrimination as a barrier to Alzheimer's disease dementia care, and only 53% of Black Americans trust that a future cure of Alzheimer's disease will be shared equally, regardless of race, color, or ethnicity, highlighting the need for research in this area. Whether the care partner or caregiver is a spouse, a granddaughter, sisters, or a family unit, I think it is important to understand who is making these decisions and how these decisions are being made to develop ways to intervene. I'll discuss 2 of my dissertation studies and a pilot project I completed during my dissertation that is now in press. 14 articles were included in this review that focused on examining the state of the science regarding formal care use. And I know I've said formal care a lot, but basically it's just paid healthcare services, which are usually given by an institution. So it looked at formal care use by African-American persons living with dementia and African-American care partners. 3 themes were identified. First, African-American care partners reported a need for more formal care in their geographic region, especially regarding nursing care, physical therapy, case management, and receiving a comprehensive examination for African-American persons living with dementia. Second, African-American care partners expected formal care providers, that's physicians and nurse practitioners, to assist them in making formal care decisions. And third, African-American care partners desired formal care use for the persons living with dementia. This publication examined daily decision-making and other factors like educational status, cognitive impairment of the person living with dementia, and the relationship type of the caregivers, whether or not they were spouses or non-spouses, in 62 dementia dyads that could influence the quality of life of African-American dementia dyads. The results from this publication were that African-American persons living with dementia had significantly worse quality of life when they reported less daily decision-making involvement and had caregivers who were non-spousal caregivers compared to those who were cared for by their spouses. African-American caregivers or care partners had significantly worse quality of life when they reported greater dyadic strain in the relationship and when they were non-spousal caregivers. Most non-spousal caregivers were adult daughters and daughters-in-law. I wanted to examine how formal care and daily care decision-making occur in African-American dementia dyads qualitatively. Key results describe decision-making for both daily care and formal care in 3 ways. Shared decision-making is when the members of the dyad are working as a team to make a joint decision. Absence of shared decision-making is when one member makes the decision without any communication with the other member. And dyadic communication is where there is a discussion between the members of the dyad, but the decision is made by one member only. When we think about daily care and formal care separately, daily care decision-making was led by the person living with dementia, whereas formal care was predominantly a shared decision. The final decision maker was the person living with dementia for formal care, which tracks since they make the decisions alone. However, an interesting finding regarding formal care was that the final decision maker was predominantly the person living with dementia, and within dyads, there was congruence regarding the final decision maker. I will say that these care partners made a conscious effort to include the person living with dementia. Here are a couple of takeaway points. African-American adult daughter care partners or caregivers, as well as the person living with dementia for whom they provide care, may be at greater risk for worse quality of life, highlighting a subgroup of care partners who need further investigation. And formal care decision-making is a complex process already that has had limited research focused in this area, especially when we consider health disparities, cultural norms of African-American women, which I did not go into much here today, and family norms regarding how this decision-making processes occur. Thank you.
Thanks, Dr. Bonds. That was absolutely fantastic as a start off for today. And I am now going to talk a little bit about liberalizing access to high quality person-centered care for persons living with dementia and their family care partners. And we'll build a little bit off what Dr. Johnson has said, and then Dr. Powell will move forward from there towards the end, and then we'll bring forward into a conversation together. So just to give a little bit of thought to this and background, most clinical trials and dementia specialty care occurs in non-diverse, middle to high level socioeconomic status white individuals in this country. And most generalist clinicians across disciplines are poorly trained to care for persons living with dementia and their care partners. And it largely falls to primary care providers to provide care to persons living with dementia and their care partners without the effective tools to actually understand how to provide that care. And so we end up with poorly prescribed medications that can make symptoms of dementia substantially worse, a lack of focus on social needs as well as non-pharmacologic interventions, and a frustrated clinician base that doesn't really feel like they're addressing the needs, but doesn't feel like they have the tools to address those needs. So it becomes this self-fulfilling prophecy. And so it can be really frustrating all around the system, from both the clinician side and the family caregiver and person living with dementia side of things.
Excuse me, Dr. Brody, you may need to switch your slide to the other screen, because we're not seeing the slideshow.
Okay, let me try sharing it again. How about now?
Got it. Thank you.
Okay, sorry about that. So some of the questions are, what do care partners really care about, right? So maintaining a positive relationship with their loved ones is really important. And you know, if we think about positive relationships, a lot of the care system is really focused on deficits, not on how we maintain positive relationships. And there are cultural differences on how care partners from different cultural groups experience positive versus deficit relationships in helping and performing day-to-day tasks, helping their loved ones maintain independence, helping to really manage their comorbid medical conditions while also limiting behavioral symptoms and trying to maintain some level of normalcy. So the unfortunate thing is, this is not how the healthcare system ends up focusing on our work, and ends up being on trying to limit decline with medications that don't really work, trying to manage symptoms with medications that don't really work and can actually make things worse. And we end up with not addressing what the care partners want, not improving the quality of life for the persons living with dementia. And so, this is what they receive instead: antipsychotics, Aricept, and maybe, depending on some ill-founded advocacy from patient, caregiver, stakeholder groups that receive large donations from Biogen, aducanumab, which if you want to learn more about aducanumab, why the FDA has said, the FDA advisory committee said unanimously, do not approve this drug, yet these advocacy organizations continue to push for it. I encourage you to listen to the Jerry Powell blog podcast that really discusses this from about 3 weeks ago now. So as we move away from this and try and focus on, instead of these false hopes of medications that don't work, and hopefully there are some coming down the line eventually, but aducanumab, antipsychotics, and Aricept are not amongst them. What do we really do right now? And so, let's think about where people are receiving care. They're receiving care in their hospitals, clinics, practice offices, and nursing homes, and other adult day health centers and long-term care settings. Where they're not receiving care a lot is at home, which is much easier for a lot of persons living with dementia and their care partners, not unanimously, not all the time, but is much more patient-centered, but much harder from a clinician standpoint, because then it reduces productivity, so to speak. And but in the end, there are ways to get around some of this. And so how do we liberalize high quality care? One of my colleagues, Dr. Monica McMore, uses a schema of retrofit, um, reform, and reimagine. I'm going to take a slightly different twist on that. That's a little bit derivative of it, but retrofitting our existing practices and re-envisioning how we can empower persons living with dementia and their care partners moving forward. And so from a retrofit perspective, we can provide effective training, but on their own without changing the systems, that doesn't change practice. So we need to change systems along with training to improve our existing healthcare systems. We need to retrofit by adding social workers, care coordinators, community health workers, and more person and caregiver-centered approaches to care. And we have some ways of doing that. One of the programs that I work on is Alleviato Health, which involves integrating training, caregiver education, mentorship, treatment algorithms, care plans, and mobile health interventions and nudges to improve care for persons living with dementia and their care partners receiving home health, hospice, and home-based primary and palliative care. And we have ongoing studies in all of those areas. And we also need to think about other places. So we go to where the caregivers are. We can also think about telephonic ways, removing the healthcare system from the equation for the extent possible. And there's a lot we can do without the healthcare system, and particularly with non-pharmacologic interventions, and working through informal social networks and technology to enhance this. And so these are some of the ways that we'll be able to re-envision care as we're moving forward to really provide a more person and caregiver-centered approach to living well with dementia. And so I'll stop there and hand things over to Dr. Powell.
Thank you. Those were very inspiring talks. We're very much on a theme here today. And part of what I'll be saying is that we absolutely need more work, exactly like what Dr. Bonds-Johnson and Dr. Brody have been talking about today. So the focus of my work has often been on improving quality of life for people living with dementia and their caregivers. Most recently, I am chairing a committee for the National Academy of Medicine. It's just beginning to wrap up its work and should publish its findings. And that committee was asked to put together a roadmap for the next 10 years of social science research that will support people living with dementia and their caregivers. And I'm going to walk through with you some of the things that we heard in our public meetings from people who wanted to inform what sorts of research that we would be calling for. And you'll hear echoes of what you've been hearing in the earlier presentations. So walking through things to do with dementia, both people living with dementia and their care partners really called out the way we do diagnosis in dementia. For many people, one of the quotes that really stuck with me was, "It was like someone dropped a bomb on me." Strangely, there are many people who say, why can't we do what oncologists do with a cancer diagnosis? At this point, the standard of care in cancer diagnosis is not just to say, I'm so sorry to tell you that we do find evidence that you have cancer, but actually to move forward from that very beginning point to sort of say, let's think about not only how this affects your body, but how this affects your life. How can we connect you? How can we help you figure out what services you might need, what we have on offer, and how we can bring that? That is very rare with dementia. Even in very large major medical centers where there's tons of research, tons of services, they've got all the biological tests that you need to make the diagnosis of dementia. But in many, many places that are quite, excellent in many respects, there is not that handoff that will help support the person with dementia and all of those who care for them. There is a really abrupt, okay, that's it, you've got it. I can give you a medicine, won't really do much. Why don't you come back in 6 months? I really have nothing else to say to you. And I know, I'm not trying to bash my colleagues. I know that that is not what they are attempting to do, but that's actually the standard of care, and it's unacceptable. And that's what it feels like to people who are receiving it. So really thinking about how we can do a better job, how we can connect the biological piece of this, telling people what's going on in their bodies, with the human need to understand, well, what does this mean? Can I still work? Do I need to move? How can I protect my money from scams if my judgment isn't going to be good anymore? What are the things that I need to know that I can do to make sure that I continue living the best life possible for as long as possible? So there's so much to say about all of this, but I'm going to pick out just a few quick things. In terms of focusing on caregivers, there's a real sort of sharing of the experience of the person living with dementia and the caregiver. Both suffer unnecessarily, I would argue, from extreme isolation. In many communities, once a person has the diagnosis of dementia, not only they, but the person who cares for them may really see a very dramatic and visible fraying of the connections that bind them to the rest of the community. So this is something that is completely separate from the illness. The illness is bad. Yes, we don't have a cure. But part of what makes it bad is what we do or fail to do for people who have that illness. So this sense of isolation, which, my goodness, was truly horrific for people living in nursing homes during the COVID pandemic. There was a wonderful study done by Altarum, kind of collecting the experience of people living in nursing homes in COVID. And one of the quotes that really stuck with me was, "If COVID doesn't kill me, the loneliness will." And I think that really does capture the experience of so many people in nursing homes. COVID made it worse, but that was an issue ahead of time as well, and one that is really inexcusable. We need to figure out better how we can deal with isolation, how we can integrate both the caregiver and the person with dementia into our communities. The other thing I'll mention, in reviewing the research on caregivers, there was a significant dearth of good research, exactly of the kind that Dr. Bonds-Johnson is describing. So much of the research that we have really does not identify minorities, looks at caregivers who are maybe 15, 20 million people in the United States as if they're one person. There's no way that 15 million people doing very different jobs for some family members who are in the beginning of dementia and have particular and relatively modest assistance that they need, and other people at the very end stage of dementia who are really unable to participate in activities of daily living and require intimate, difficult physical care. Those, even for the same person, that's very different needs at different points in the dementia trajectory. But how that impacts people by race, by ethnicity, by gender, by their own age, by where they are in their life. Are they also taking care of minor children? Are they taking care of other people? Do they have a job formally that's being paid that they need to do too? How do we understand the vast variety of experience of caregivers? Because we cannot do better in supporting caregivers until we do better in understanding who they are and what their needs are going forward. So I think that also speaks to Dr. Brody's work, thinking about how can we really integrate and do all of the different research that we need. And I'll just say one further thing. Dr. Brody's comment on aducanumab is almost sort of triggering for me. This is a medication that whose progress I've been following, or ill progress I've been following for some years now. The evidence does not support its use. Everybody who knows about Alzheimer's disease would love to have a cure. That would be so great. But do not let that hope let us really kind of worship a false idol here. There is not evidence that this will support people with dementia. Irrespective of that, it will be enormously expensive. And I'm not coming from a finance point of view. If it worked, we would have to figure out how to get the money that we would need to use it. But there really is very little evidence that it does. And it does have side effects. This is being pushed by well-intentioned people in many respects, and some who are more interested, arguably, in the profit motive. It is going to be decided soon, and this is an enormously important decision. Wonderful editorial by Caleb Alexander and others in JAMA about 3 weeks ago. And I, like Dr. Brody, I recommend that you educate yourself about this if you've been hearing about it. I will quit there, and I hope now we'll have some questions and be able to have more of a conversation.
Thank you very much, Dr. Bonds-Johnson, Dr. Brody, Dr. Powell, for a very, very wonderful, stimulating introductory remarks for this program. One thing that was just mentioned by Dr. Powell, which I'd love to hear the three of you comment on, is the diagnosis part of dementia. What happens when somebody denies the fact that they have dementia and they walk out of the office, out of the clinic, out of their primary care physician's office, wherever they might be, say, oh, they're wrong. It's not me. I don't have it. And I often think of the diagnosis of dementia is kind of like the stages of death and dying and Kubler-Ross's stages, and then wonder how that evolves. So I'd love to hear some comments on what happens when people don't accept the diagnosis.
Well, I could jump in, but I'd be very eager to hear what my colleagues say too. I think we need to address this in different tiers. There needs to be the long game, and there needs to be the immediate response. By the long game, I mean, dementia suffers from enormous bias. There are many people, including experts who study dementia, who, if you ask them, what would you do if you learned that you had dementia, will say, oh, I would kill myself. I'm not here commenting on the sort of politically very fraught issue about whether or not we believe in aid in dying, but I think we can all agree that we would like there to be a better alternative for that, for everybody. That, you know, whoever has this diagnosis, for every day that you choose to be with us, we'd like to make it the best day possible. And there is so much bias and so much stigma that I think for many people, they really feel, even starting on the first day, the day of diagnosis, this is worse than death. So playing the long game, we have to get rid of that stigma. We have to really figure out how to do as best we can. It will be a bad disease, but it's really the burden that we place on it of the stigma that makes it so much worse than it needs to be. And other than that, I think short term, and I'd be curious to hear what you guys say. I mean, I think we need to, before we get into it, we need to say, listen, before we talk about what's happening, our standard here is that we'd like your permission to reach out to you in a few days or a week. You can certainly contact us anytime, but we'd like to reach out to you, hear how you're doing, hear how things are going. This is a very heavy matter, and sort of have that permission in place so that if somebody does storm out, and I think you'd need maybe to get information, who's your vice president, who's your support network. Not everybody has one, but begin to think with, who can we do that? I'm a bioethicist. I love privacy. I love autonomy, but we sometimes injure people by focusing too exclusively on that and not allowing us to help people build the support network that they need in this kind of crisis. So that's where I would start. I'm curious about what the others have to say.
Yes, I can go next. Yeah, Dr. Powell, I appreciate the explanation of the short game and the long game. I think the other thing I would add is that I'm a big proponent of meeting people where they are. As a psychiatric mental health nurse practitioner and clinician, and worked in long-term care, you know, I've had dealings with individuals who I've had to sort of give that diagnosis to, and then individuals who I've collected along the way who had the diagnosis. And I think understanding if this person is coming in seeking the diagnosis, knowing that something is wrong, that's a very different patient encounter than someone who was brought in by family members or who was expecting a different diagnosis than what was given. And I think understanding that the stigma around this diagnosis is difficult to handle, and that we need to just sometimes extend people grace. And so I like the idea of understanding that in the moment, he or she, they may not be able to accept that diagnosis, and I'm okay with that. But understanding that I really need to follow up with someone, because you know, the earlier we can get connected with resources, the better the outcomes. And recognizing that eventually as the diagnosis progresses, they will forget that they have the diagnosis. And so there are some instances where with certain families, I don't mention Alzheimer's disease or dementia specifically in a meeting. It's more about how are you feeling today and checking their mood and getting some insights about their day-to-day. So just recognizing that every individual is different, and that we as clinicians and researchers sometimes have to come at it different. Kind of that idea of there isn't one caregiver, care partner, there isn't one person living with dementia.
I think the one thing I'll add to this is, in palliative care, we've really come to this approach around standardizing communication training quite a bit. And there's some really wonderful programs out there that have mainly to date focused on cancer, focused on end of life decisions in a hospital ICU. But we haven't really had these types of programs make it out into the field, particularly around Alzheimer's disease and related dementias. And language matters so much in this. It matters both from a clinical perspective, from a humanistic perspective, and from a research perspective. So in our research studies where we're recruiting people, we talk about memory problems. We don't worry about the diagnosis that's coming with it. And except for the very small subset that end up in an Alzheimer's disease center, most are going to be diagnosed in a non-specialty neurologist office, a psych mental health office, or a primary care office, and they don't have the language to use around this and around the support that we need to provide. And so we do have structured communication, and we've done this, we've really integrated this within cancer care a lot more. And I think it's something that we really need to start to think about how we address within a Alzheimer's disease and related dementia framework as well. And that it's not just here's your diagnosis and, oh, I can give you Aricept and it probably won't work and it might make your stomach upset, but it could delay the decline by a teeny bit, and good luck with that. Versus, here are the supports that you have, and here's how we can help you to live as full a life as possible with this illness. And so it really comes back to the language component of things as well. But there are going to be people who are not ready for that diagnosis, just like they wouldn't be ready for a cancer diagnosis, a heart failure diagnosis, whatever it might be. And it takes people time and space to get there sometimes, if ever. So that's just part of everyday bad news breaking. Just harder in this instance where we have no kind of disease modifying treatments at the moment.
Well, that brings us to one of the questions that I had, but it also is a question from someone in the audience, because you mentioned giving them support services, a diagnosis. And the question is, how can I provide, as a social worker, how can I provide further support systems for for patients when there is a suspicion of diagnosis of dementia? How do I locate suitable services to further support those diagnosed with dementia?
I can talk a little bit about how we, within our Alleviato hospice program, have really formulated the different roles of the different IDT members. And so we use an IDT in terms of developing the program and implementing it. Tessa Jones, who is a palliative social worker and a PhD student in the Silver School of Social Work here at NYU, worked with us on this. And the supports are many that social work can provide. And I think the first thing is people forget that social workers are these awesome providers who have so many resources at their fingertips and can really help families through challenging times. I think the second component of this that I really focus on, and where we focus within our program, is on the social workers providing psychoeducational information on working through caregiver training, working through what are the issues that really the caregiver and families want to address. So we use a problem-solving approach, which is well evidenced, the antecedent behavior consequences discussion approach, ABCD. So you have the behavior that exists, what causes the behavior, what are the consequences of the behavior, and then the discussion is what are the potential ways we can address this behavior, which are the biggest concerns that family members tend to have is around behavioral and psychological symptoms of dementia. And so it's supporting them through those things there's a huge evidence based on non-pharmacologic interventions. It just hasn't made it into the hands of real world providers who are not dementia specialists. So that's a lot of what we do. So I'd say a lot of it is really learning some of the components and then interfacing directly with the caregivers on what their priorities are and addressing them through a problem-solving approach.
Anyone else want to add to that?
I'll just comment. I think it is so fantastic when there is a social worker who's on the case, because this is their superpower, is to sort of find out what are the resources that are available in this community. And wait, I know there was this woman who was doing, but I think across the country, the resources that are available are very patchy. There are great services in one place, and a similar kind of community, one town over, may really not have much at all going on. It's also the case that there are even some government programs that are pretty great, but they assume that everybody can find them. And there's this process of all over the country being repeated over and over again. Diagnosis of dementia comes to each new family, and each new family has to reinvent the wheel, figuring out where you can go, where you can find services. There's a presumption that everybody is incredibly literate on the computer. Everybody has Wi-Fi. Everybody knows how to do all these Google searches. It's great if you've got, and I happen to be very lucky because one of my kids is an adult daughter who's an IT person, right? So I'm in great shape. I'm going to assign her the task of finding what services I need. If you're not lucky enough to have such a person by your side looking out for you, you could be in trouble. And many of our caregivers, if their spouses are also older people, didn't grow up on the internet. And so we haven't done, there are some good programs out there. We haven't done as good a job as we need to of making sure that they jump out at you, those resources. It's easy for you to find them. You just can't even walk without having those things coming and finding you. And we've made it too hard. You have to be too much of a Sherlock Holmes to figure out sort of what's available in your community for a lot of people. And a lot of people don't have Wi-Fi. That's another sort of problem. Both urban communities and particularly communities of poverty and rural areas, there's very spotty Wi-Fi. So it makes it really tough, and it increases that isolation for people.
Yeah. Anything, do you want to add anything, Dr. Bonds-Johnson? No. Okay.
I think they covered it beautifully.
And I have one thing to add, and it reminds me, it makes me think about the IHI and the framework of the 4 M's and what matters, and how important it is, particularly when someone is newly diagnosed with dementia, what really matters to both them and their caregivers. What is it that they want, not what I want or the physician want, what do they want? And I think that's something that we are just learning to focus on, what matters to the person and the caregiver. Another question I have is when, I think about how we worry about direct caregivers. It's one of the things the Hartford Institute does, and Dr. Brody's family program prepares nursing, CNAs, certified nursing assistants, direct caregivers to care for people with dementia. What kind of preparation do we have for family caregivers to help them deal with loved ones who they're caring for with dementia?
I will say, I'll mention my mentor's work, and that's the work of Dr. Kenneth Hepburn and his Telesavvy Savvy Caregiver program. I'm not sure how accessible it is at present, but I know the goal is to eventually get it in the hands of caregivers. And so it works on really helping individuals gain skills and knowledge so that they have a sense of mastery in caregiving for a person living with dementia.
Any other?
Yeah, and beyond, so I know Dr. Hepburn is working on that with Dr. Fortinsky. They currently have a pilot award from the Impact Collaboratory to examine how to expand this in a pragmatic way. I think there are other ways, but a lot of it comes down to trusted information and where you're receiving that trusted information from. So for instance, we still see a lot of people who go out there and get vitamin E or these supplements that don't do anything or can even be downright harmful, as can vitamin E in high doses, which was proven about maybe 10 years ago now. And so we do see that there's a lot of harmful things that can occur from utilizing Dr. Google. On the other hand, there are some really great resources out there. And I know we discussed maybe not agreeing with the aducanumab advocacy, but the Alzheimer's Association has a tremendous amount of resources available, both in terms of their caregiver hotlines. And so many of the local Alzheimer's Association chapters have their own local hotlines, as does the national organization. And they also have caregiving kind of educational material for those that have other forms of dementias. There is the Lewy Body Dementia Association and several others. So I think there is some really good information out there. It is very static, however. And so I think, one of the things that Dr. Hepburn's work is on is creating more towards mastery and more towards interaction. And I think that's really where we need to be to help personalize. And I think there are opportunities, but we also have to think about there's not going to be a one size fits all. And all of different populations and communities have different ways of considering what's important within caregiver mastery. And so we really do have to think about how that is addressed. Dr. Hepburn's has been used in a large African American, Southern African American and Black population. And there are opportunities, though. Caregiving in Hispanic and Latinx populations is very different. Caregiving in Asian American populations is very different. So we really do need, from a cultural sensitivity perspective, to really expand what we're doing and make it more dynamic than passive information moving forward.
If we could build on what you just said, Dr. Brody, and talk about the ethnicity and how does that matter? Does the ethnicity and culture matter when we are saying what supports do caregivers, family caregivers need? Does it matter? Dr. Bonds-Johnson?
I'd say it matters. It's probably one of the most important things. We, as a country, and after 2020, are now, I think, starting to realize that there are at least two different Americas. And if we don't consider the lived experiences of Black Americans, African Americans, Asian Americans, Latin Americans, the Latino population, if we don't really start to look at what matters to these individuals from a cultural standpoint, from a family dynamic standpoint, we're never going to reach them the way we want to. Our research is going to be lacking, and the services and the resources that we provide will be lacking. So one of the comments I made in my presentation was that adult daughters are sort of this subgroup of caregivers that are not necessarily doing well. When we look at general dementia research, it's often spouses that came out as having significantly worse quality of life. And because, and they associated that with spouses providing more care. Well, in our, when you think about who is the main caregiver for a non-Hispanic white person, it is typically a spouse. But that is not the case when you're looking at an African American. African American are typically provided care for by their adult daughter. So if we're thinking about an older white man who is the caregiver of, a woman with dementia, Alzheimer's disease or related dementias, compared to, a 50-year-old, 40-year-old African American woman caring for her adult parent, I think the dynamics, just in thinking about gender, race alone, are enough to say we need to do a better job. We cannot keep lumping groups of people together and saying, oh, all the Blacks do this and all the non-Hispanic whites do this and all the Asians do this. Like it's a terrible thing that we do in research. And so I'm grateful for this opportunity to really shine a light on really looking at cultural and racial differences.
Wow. Any other comments on that one? You addressed it very well, Dr. Bonds-Johnson.
I think the only thing I'd add to that is that, we tend to lump people in research so that we can do our analyses. There are some great papers on why not to do that. And there's also some great papers on how not to come from a deficit standpoint and look at things uh, as negative disparities when they are sometimes also cultural differences that are involved. Keith Whitfield, who is now the president of UNLV, has the prototypical paper from about 2008 on this. But there's a lot that we can focus on within group differences as well, because there are individuals who have more or less strain within groups. And I think the Lin-Manuel Miranda made this point that within the Hispanic and Latinx population, you're trying to group together 30 or 35 different countries into a single group, right? Just like people who are raised in the southern United States are going to be very different than those raised in California, Iowa, so we may be a melting pot in some ways, but we are not in other ways. And we have not hit the level of precision that we need in terms of teasing those groups. And some of the cultural, I don't want to say generalizations, maybe norms, but cultural norms apart, because there are always people that sit outside of the cultural norms, but we have a long way still to go. And there's been some great work from a number of different researchers looking into this, but we still have a lot of work still to do, particularly in ADRD and family caregiving.
I agree with everything that the other speakers said, and would just go back again to the long game issue, which is that one of the ways we need to support caregivers is that it will be better for every caregiver when other people also understand something about these challenges. So the more everybody kind of knows what dementia is, and it's not something we need to hide, it's not something to be ashamed of, that person can't come to the high school graduation. And what if they do come to the graduation and they yell out, hi Cynthia? It's like, that's fine, that's kind of adorable actually. So I think hiding people, making it shameful, all of that, no matter who you are, there are some commonalities. And the sort of shame and the stigma and our lack of general education about what dementia is and what causes it, lots of things. We are still learning about that, but I'd like to see us still do much more with that too, even back to elementary school education and on up. I'd love to see kids get into caregiving activities in the community and really begin to learn from the youngest possible age what it is and how honorable it is to be a caregiver.
And that question or that answer, Dr. Powell, leads me into one of the questions we have from the audience. And I was somewhat struggling with it, how to provide support to a child caregiver of someone with dementia. What are the cultural impacts of children in providing care to someone with dementia? And who wants to take the first answer of that?
I'll say a word, but I don't know that. I haven't seen much literature on people who are actually younger than 18 who are caregivers, though we know they're there. And certainly there are many young people who live in a larger family, an extended family, with a person with dementia and do share in that caregiving. I think any act of caregiving in some ways, it's not that long ago that we used to tell parents that if you had a child with a disability like Down syndrome, that'll be terrible for the brothers and sisters. You have to get that child out of your home and into an institution. Our thinking now is the opposite of that. First of all, every member of your family can be treasured, and it can be actually a wonderful learning thing for a child to be in a family with people who are who have disabilities, who are differently abled, who have all sorts of differences from the sort of cookie cutter normality that we pretend is what's normal, but it's not. So I think we don't know what it's like. There are certainly many children growing up in homes with that. I have spoken to some young adults who are 18 to 25 who end up becoming primary caregivers with people with dementia. And they, I think, often feel like the odd man out. A lot of the support groups are not designed for them. A lot of the programs, it's very hard, I think, for them to find people like them that they can talk to. Some of the local Alzheimer's associations, again, are doing great with having groups for younger caregivers and stuff, but it is not so easy to find that across the country, I'd say. And I'm curious about what the other speakers think.
I don't have much to add. I do know that Elizabethsboro, who is a PhD student at Emory University, is focusing her dissertation on adolescents who have a parent with early onset dementia. And so I think there is just much more work to be done. And the conversations we've had with her, it's hard to give guidance with a child because I don't know if there's another person in the home, because, thinking about this diagnosis of dementia, eventually that parent would need care. And so I'm not sure how old this child is to really be able to provide a lot of services, but definitely would need services to assist with that care.
I think there are two interesting pieces here, right? We're seeing individuals having children much later in life than they used to. And so we do now see, and particularly fathers who are having children when they're in their 50s and early 60s, which makes this more likely. Women are having births sometimes in their 50s now. I think there was a celebrity the other day that was it Naomi Campbell, I think, who's 51 and just had her first child. So I think we are going to see a little bit more of this because of advances in childbirth and IVF. But on top of that, when we're dealing with our early onset folks, I think the other challenge and thing we really have to support is early onset Alzheimer's or frontotemporal or Lewy body are really genetic in nature. And so you not only have the challenges of caregiving, whether you're 15, 16, 18, 22, what have you, you also have the challenges of am I next, right? Our 75 and 85-year-olds who develop dementia, most of that is not genetic as much in nature. There's still APOE4 and kind of some of these other pieces that may make you slightly predisposed, but our early Alzheimer's folks, our early Lewy body, it's set frontotemporal, that has a very strong genetic makeup. And so some of the counseling has to go towards some of this genetic counseling as well, some of the stresses that are coming, am I next? And I think that's something we don't really talk about because it's not, we don't know how to do it. Unlike we should know how to do it because we do it in Huntington's, right? But we don't really focus on it yet. And so I think as some of the more genetic components beyond APOE4 really come out into the clinical world and we really get this more into real world practice, we're going to have to see some changes in how we approach this as well.
Well, that leads very well to the last question we have from the audience. And I think about the book written by Dr. Powell, which talks about exactly this of familial traits in a family and how does one prepare? And the question is, what is your recommendation when you see a trend in a family? For example, 2 brothers and a sister diagnosed with Alzheimer's. The onset seems to be in the early 70s. One sister is starting to show signs at age 80, but she's not diagnosed, and the family is trying over-the-counter supplements such as Neriva. So when there is a familial history, is there a different way of approaching primary care?
That's such a great question. There's a couple of questions in there. Many older people, you know, you sort of feel some cognitive aging coming on, a little bit harder to pull up those names and, you know, remember things quickly. So a lot of people are anxious about minimal cognitive impairment and other things. So the supplements and things like that, it's such a disaster. They're not necessarily all harmful, although as Dr. Brody mentioned, some certainly can be. They're almost all quite expensive. And if you were to take that and put it towards something that is more likely to be beneficial, like a really comfortable pair of walking shoes, if you actually got out and were walking or doing whatever is safe for you, and really the best exercise for anybody is the thing that you'll actually do. So you don't have to like have this expensive rowing machine or something like that. Pick something, you know, if you have a friend that can walk and you'd like to talk to, that's just a really wonderful thing because it connects you socially while also getting both of you outside. So take that money that you would spend on supplements and use it for something that is more likely to benefit you. It doesn't cure or prevent dementia, but actually it's great for all of you, great for your cardiovascular health. And it's probably the best thing we know in terms of slowing down and preventing and slowing down the development of dementia as a general matter, because most dementia is multifactorial. Now, does dementia run in families? Sure. There are lots of different factors, everything from how you eat and your level of education and how much exercise, all of that, plus what's running around in your genes. Just because if you have a family of 12 kids and 11 get dementia, it doesn't actually mean the 12th will. We're all mixed up with our genes. We all have different combinations of what we get from our parent, both the good and the bad. So if it runs in your family, and it runs in my family, both my mother and my grandmother had dementia, you should be cautious and aware. You should learn about lifestyle factors. What are the things that you can change and ameliorate, and do those things? Be active, watch your diet. Don't smoke cigarettes. They're really bad for you no matter what you're worried about. So do the things that you already know are healthy and try and stay with that. So that would be the best thing. I think we don't have really good predictable measures. There are lots of very expensive tests that can tell you whether or not you have a risk factor for dementia. So you could get the super fancy PET scan that will tell you whether or not you have an increase of amyloid plaques in your brain. But before you pay all of them, you can't even necessarily get it paid for by insurance at this point. But before you do that test, you should realize that at death, there are a lot of people who don't have dementia, die cognitively intact, and have that excess amyloid. So it doesn't tell us really that you're going to develop dementia. And similarly, there are people who develop symptoms, about a third of the people who develop symptoms that look like Alzheimer's dementia don't have increased amyloid. So please don't get that plaque. We don't have the science today to tell us how good a predictor it is. If it runs in your family, say, I'm at risk. That's kind of a bummer, but we all have pluses and minuses in our DNA. And let me just try and be sober and do those things that I can do, have as good a life today as I can, and see if I can kind of, you know, load the dice a little bit in my favor by taking some positive steps and on forward. So that's how I try to live, and what I also advise patients in. There is no single test today that I think is going to tell you accurately whether or not you will develop dementia, other than clinical exams that tell you that you do have it today, or maybe you have minimal cognitive impairment. That does show that. But if you're at risk, you're at risk, and the test can't really tell you better than that. So that's sort of where I would go with that. I don't know, do the other speakers disagree, or how would you handle it?
I just like to hammer over the head that we are actually seeing in society overall in the population a decreasing prevalence per 1,000 people of dementias, and that's because we're doing a better job of cardiovascular disease management. And so a lot of this relates to what we used to think, that Alzheimer's disease was just plaques and tangles, but we now really do. There's a cardiovascular component to Alzheimer's that can speed up or slow things down. There's a certainly vascular dementia is cardiovascular in nature. And so really a lot of this is about preventative health. And when we look at this, we need to think both about how do we engage communities in preventative health, particularly cardiovascular disease health, and what are the systematic issues that relate to this? Is, you know, if we look in LGBTQ populations, we know that stresses, poor access to healthcare, and bias in healthcare are huge issues that make worse cardiovascular disease outcomes. And we have a fantastic faculty like Dr. Billy Caceres, who's really focused on this aspect of this at Columbia, who's one of our graduates. You know, in African American and Latinx and Hispanic populations, there are similar genesis of this through different pathways. So, you know, we're doing a better job. We are reducing the overall prevalence of dementia, but there are groups that are at higher risk because of the systematic biases that exist within our healthcare system and the paternalistic way that we approach, you need to do better with your diet, you need to do better with your exercise, versus a really more patient-centered and coaching approach to improving lifestyle and wellness. So that just hitting on the head what Dr. Powell discussed on, and you know, throwing in some of these other pieces to it. But I completely agree with what you said.
And as a final comment, Dr. Bonds-Johnson, I think that opens the door for you to talk a little bit about the impact of, I mean, Dr. Brody just talked about the impact of cardiovascular disease on dementia. We also know that the African American population is at a higher risk for cardiovascular disease, has a higher percentage of them have high blood pressures very early on in life. How does all this then move into how do we prevent, or how do we decrease the risk of dementia in the African American population? If you could come up with the answer, it's a magic wand, but at least can you give us
no pressure? No, I think recent research, which is looking more at racism instead of race, because initially in a lot of research, we've been content with just saying, well, African Americans have this and sort of leaving it like it's a race thing. And we know that race is a social construct and it's not biological. And so really getting to some of the core factors. And I think this is where some cultural norms and things along that line play a role. So, you know, in a lot of research, it's often been reported that African American caregivers have better quality of life and they have no problems. And so it's been translated that when we compare African American caregivers to non-Hispanic white caregivers report worse quality of life. So, you know, African American caregivers must be fine. But when we really start to think about the fact that these African American caregivers are predominantly women, and if we look at such cultural, I guess maybe not norms is the right thing, but there's been research done around Black and African American women and this idea of the strong Black woman or the superwoman schema. And so it really isn't comfortable in my DNA as a Black woman, be it outside of my clinical role, outside of research. It's not okay for me to be able to say that I'm not doing well, especially when I'm caregiving for someone who is a family member or a relative. That's culturally not something I would say. I'm not comfortable saying it. Whether I'm sad, burdened, depressed, overwhelmed, it isn't in my vocabulary to be able to say those things. And so are we then missing the mark when we're having such research studies and not really asking questions, but giving them a survey that wasn't really adapted for African Americans in the first place? I think the other thing, where was I going with this? That's important to look at is that as Dr. Powell and Dr. Brody both mentioned, the healthcare system isn't necessarily set up to allow for cultural norms. So for example, a lot of African Americans, as I mentioned, like to have family buy-in. They like to have family support before they make healthcare decisions. Our healthcare system isn't set up to say, bring in your aunts and your uncles and your nephews and everybody that makes a decision. And I, as the provider, as the physician, as the doctor, will sit down with you and discuss the best options. that isn't how our healthcare system is currently set up. But I think having it set up similarly to something along those lines would actually be more effective for those individuals who come from more of a collectivist, who have more collectivist values. And so, just thinking about these things when we make these generalizations and we say things in research, but really, is it race? Is it place? Is it bias? Is it something else that's going on that is influencing the outcomes of the individuals that we're treating and that we're examining in our research?
Thank you. I think that's a wonderful wrap up. I appreciate the wisdom and the tremendous dialogue that we've had here. Thank you so much to all our panelists, Dr. Bonds-Johnson, Dr. Powell, Dr. Brody, for this very, very informative and stimulating discussion. I also would like to say that the Hartford Institute will be holding its next webinar. It'll be the Case for PACE expansion. Please join us on July the 12th from 11:30 to 12:30 to hear more about this important and timely topic, but more information will be coming out on our website. Thank you everyone for joining us today, but a very special thanks to our panelists. Bye.